Thank you for joining us for this Surgical Oncology Clinics podcast devoted to precision oncology and cancer surgery. The 4 articles discussed, as well as 10 others, are in the April 2024 issue, Volume 33, Number 2. This series is available for individual print or online subscriptions. Visit www.surgonc.theclinics.com to subscribe. This series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter at Surgical Clinics, and you can find our podcasts on YouTube, Apple Podcasts, and your favorite audio streaming platforms. Thanks for listening.
Thanks so much, John. Really excited about this podcast today, and to talk to my good friend and national and international expert on this topic around precision medicine, Dr. Jason Siklik. So welcome, Jason.
Thank you very much, Tim and John, for the invitation to speak today.
Well, I really think this is such an important topic in cancer, and where the field is moving and how we treat our patients. I think the first thing I wanted maybe just to talk about a little bit, Jason, is just this article by Dr. Elvin around kind of understanding the landscape of clinically available molecular testing and precision medicine. For maybe some of us who are the uninitiated, if you will, this whole idea of precision medicine can be somewhat ambiguous. And maybe you can just kick off by kind of setting the stage and helping us to understand the landscape as Dr. Elvin laid it out around precision medicine, molecular testing, and how this may apply to our patients with cancer.
So really, that's a great question. And it really sets the stage for what, the evolution of molecular medicine is. Maybe as a starting point, you can just kind of think about what is precision medicine? How is that defined? And really, it's thinking about identifying biomarkers or molecular targets in tumors and trying to identify ways to either target them, to use them for prognostication, for using them for risk stratification in treating our patients. As surgeons, a lot of our focus is often on, at the operating room table, but as cancer surgeons, we really need to be thinking about the big picture of the patients. And so bringing this lexicon of molecular testing into, our part of our practices is a critical part of us growing as oncology evolves over, time. The article by Dr. Elvin is really kind of broadly based, talking about the different types of testing that's available to us today. I mean, we're all sort of used to classic pathology, immunohistochemistry, which is often used as a diagnostic for making a diagnosis of a specific type of cancer, or identifying, more recently, things like HER2 as a biomarker for response to therapies that are target HER2. But where we kind of have evolved over the last decade is now the introduction of next generation sequencing of both RNA and DNA into practice. And that's at 2 levels. One is at the tumor level, where using biopsies from patients' tumors, and these can actually be FFPE or formalin fixed paraffin embedded samples from resections that even happened, years ago. The DNA and the RNA can now be extracted from that. And that's where we can start thinking about identifying genomic alterations in tumors that might lend themselves to treatment, or stratifying patients about what, treatments might be best for them. And we're now starting to evolve into the era of RNA analysis as well. The second part of this evolution is now getting into the blood-based side of the assays, where we can now start thinking about, we don't even necessarily need to have a tissue biopsy for some patients, and we can use biomarkers in the blood with really the same sort of molecular targets identified through blood-based assays that can be used for anything from diagnostics to following disease, sort of like we're often used to using blood-based biomarkers that have classically things like CA19-9 or CEA, but now we can start thinking about, is there potential to be utilizing this newer technology for following disease over time and identifying potential recurrence earlier than might be seen radiographically. And so it's really all these new parts of the technology are, allowing us to start putting, another layer of understanding of the diseases and, hopefully trying to treat patients earlier, catch disease earlier, have perhaps more directed therapies for the patients.
So maybe just to touch a little bit on that point, one of the things that Dr. Elvin kind of mapped out a little bit in the article was just the different clinical scenarios for molecular testing, the application to, cancer detection, as a diagnostic tool, as a prognostic tool, as a treatment prediction tool, and then also as a tool to monitor response and identify potential nascent recurrence. So I was wondering if maybe if you could just comment a little bit, how you see molecular testing and precision medicine applying broadly to these different areas, and where do you think, as clinicians, it has the most applicability currently and will have in the future?
So I think it's still, evolving. I think it's not certainly a one size fits all, and it's not going to be every disease. For instance, using the blood-based assays, there are certain diseases that shed DNA into the blood very well, and there's other diseases that rarely, if ever, shed DNA into the blood. A good example that's where we see a lot of shedding of DNA into the blood, for instance, is in lung cancer is one good example. And, it's being utilized as a marker for following disease, following treatment, seeing DNA mutation levels in the blood decreasing with treatment. And then if somebody's developing resistance to treatment or is developing a recurrence, we're seeing those levels going back up. And so I think we're still very early days. There's a lot of studies going around on right now across histologies to really understand what are the, when is this best used in a given disease? What are the applications where it works great, or there's certainly those applications where it doesn't work very well at all. And so I think what we know is there's a lot of questions that are unanswered, and it's an evolving field, but it's certainly something that relates to us as surgeons, especially as we are following our patients post-resection and trying to understand how do we catch that recurrence earlier. Do we need to be scanning them as often, or can we utilize some other approach to catch recurrences earlier, perhaps, maybe one scan earlier even than what the radiologic imaging might, find.
And then the other thing he touched upon in the article was just around the different kind of optimal molecular assays. And you've already kind of highlighted this a little bit, but there's, different approaches like next-gen sequencing, there's RNA analysis, there's tumor-based analysis, there's, a blood-based analysis. So, where do you think, the field is going? What should providers be aware of, especially surgeons maybe who are handling, a lot of this tissue? Is there anything that they need to keep in mind as far as assisting our colleagues in pathology and molecular and medical oncology with regards to ensuring that the tissue is in the proper state that it can be analyzed appropriately?
It's a great question. So the beauty of a lot of the new technology that most, or if not all, the commercial companies are using now is they can, rather than sort of the old days of we needed to have fresh tissue, or it had to be, snap frozen in liquid nitrogen, and it had to, be prepared in a special way. The RNA and the DNA now can be obtained from just using the FFPE blocks that were obtained from, a tumor resection that was sent to pathology and formalin fixed and paraffin embedded. and sections were cut from that, and the pathologist did all their H&E stainings. Just one more step beyond that is these testing approaches using that same exact tissue. So there's nothing necessarily special that needs to be done. So it really takes away some of the burden, on us as surgeons of having to think about some of these extra steps. The different commercially available companies that are out there that have CLIA approved assays are continuously evolving. We've evolved from, some panels have just a small group of genes. Then there's some panels that have evolved now to a couple hundred genes. And now some of the commercially available panels have the entire whole exome of the DNA. We're now moving also from just specific RNA analyses of expression of just a small set of genes, for instance, like the Oncotype DX for breast cancer, to full transcriptome analysis of the entire transcriptome, or all the RNA, in the tumor. And so we're seeing this sort of stepwise as the technology is becoming cheaper, and the companies are becoming more facile with using this, in a faster turnaround fashion. You can get most of these results within about a month of submitting them to a given commercial entity. The blood actually is even faster, often about 7 to 10 days for the turnaround for the blood-based DNA assays. And the companies are continuing to evolve as well in terms of what they are providing. So, we now can obtain tumor mutation burden, or the number of mutations per megabase, which is a biomarker for deciding about drugs, to microsatellite instability information, all from the DNA analyses that the companies are now providing as part of these analyses. And so the great thing is, as surgeons, we don't really necessarily have to do anything different or think about anything extra when we're in the operating room beyond just, taking the tumor out at that point.
That's great. Well, I wanted to pivot now. You touched, on microsatellite instability and tumor mutational burden. And so I wanted to pivot a little bit to the article by Dr. Eskander and Dr. Nishizaka on immunotherapy. Obviously over the last 2 decades, there's been significant advances in molecularly targeted treatments, immune checkpoint inhibitors, that really has transformed the way we think about treating many patients with solid cancers now. So I was wondering if you could just touch a little bit on immunotherapy in general, some of the perhaps biomarkers, if you will, related to immunotherapy, the landscape with regards to monotherapy with immunotherapy compared to, combination therapy. And we're seeing this, more recently in intrahepatic cholangiocarcinoma, hepatocellular carcinoma. So wondering if you can comment on those things.
Yeah, so just as a little bit of background, so the concept of immunotherapy is really based upon taking the brakes off the immune system and letting the patient's own body and their immune system attack the cancer. We've seen sort of this evolution over time, and we're still trying to learn what are the best patients and opportunities for using immunotherapy. You touched on 2 of the biomarkers that we now recognize as biomarkers of potential response, being the tumor mutation burden, or also called the TMB, which is the number of mutations per megabase in the DNA. And basically, tumors that have high tumor mutation burden, such as a good example being melanoma or bladder cancer, some lung cancers, tend to have a much better response to immunotherapy than those patients or those tumors that have low tumor mutation burden, and it was considered an intermediate tumor mutation burden. Depending upon which assay you look at and how those are done and which company is doing it, the the exact sort of cutoffs between low, intermediate, and high vary a tiny bit between the companies. And so there's not, I'm not going to give one exact number that is the cutoff, but that said, it's really the sort of global concept of the more mutations per megabase that you have, the more neoantigens that the immune system might recognize and therefore potentially lend itself to immunotherapy. The same thing goes with the microsatellite and stable tumors. Again, sort of similar concept of higher new antigen load and therefore more likely to respond to therapies with immunotherapy. There are several targets. The main target that we mostly think about is the PD-1 or programmed death receptor 1 or PD-L1, which is the programmed death receptor ligand 1. These are sort of the partners, if you will, that some of the drugs that are out there will target the receptor, the PD-1 receptor. Some will target the PD-1 ligand. And so, but again, it's trying to block this sort of connection, this inhibitory connection, by then unleashing the immune system to then target. There are other targets out there, CTLA-4 being another one that's been, widely studied. A lot of the, seminal work was really done in melanoma. And, we've seen some just dramatic responses to therapy with, immunotherapy in patients with melanoma. And it's both, it's single agent and or combinations of immunotherapies for this, example. As you mentioned, we're now starting to see this rolling out into other diseases such as cholangiocarcinoma and hepatocellular carcinoma, where, not every patient is going to respond to this, this therapy. But if we can try to, as we continue to learn about the biomarkers and trying to identify, better patient selection, we can then start trying to really say, okay, you're the one that's going to work. And maybe, this isn't going to be, so great for you.
And then you talked a little bit, the idea behind this obviously is taking the brakes off the immune system, as you noted. One of the things that Dr. Eskander highlighted just was some of the toxicity complications associated with this therapy. So maybe you could just touch on that. What are some of the common, toxicities that may be associated with immunotherapy?
Yeah, so, because the immunotherapy is taking the brakes off the immune system, we can sometimes see effects that are related to sort of almost like autoimmune type processes, whether it's effects on like a cerebritis type effect. You can start seeing effects on the skin, GI tract issues. And so it's really a matter of, the pendulum almost swings too far the opposite direction, if you will, causing these effects upon, almost autoimmune type effects upon the body. And so we need to be balancing that. We need to be aware of that. Generally these drugs, are given every couple of weeks. And so, we can operate on these patients after basically just holding, the immunotherapies for a couple of weeks before surgery and then starting them, a couple of weeks after surgery as well.
Yeah. So that was going to be one of my questions for the surgical audience about, how do we manage, immunotherapy in the perioperative period? And, what would be your advice in the postoperative setting? When is it safe to restart these agents?
So it's a great question. Just, as long as you're holding it generally about 2 weeks before surgery it should be sufficient. Similarly after, sometimes, as patients have complications, have infectious complications, or just slow, in their recovery. Obviously you want to have them, strong enough to tolerate it again. And so, generally would recommend, going back and thinking about restarting therapy when they've, had a reasonable degree of recovery from surgery, depending upon what was done, but, something on the order of a couple of weeks to a month or so in general, should be fine.
Yeah. So I think, one of the interesting concepts, at least to me, around immunotherapy is somewhat moving away from a very kind of anatomic specific or even, histologic specific therapy to focus more on like underlying, MSI status or TMB status. And so, in that vein, I wanted to move now to the article by Dr. Guda and Dr. Sabia that focuses on tissue agnostic cancer therapy approvals. Traditionally, we've been very focused on anatomic location or histologic diagnoses and using those items, if you will, to inform what type of therapies that we deliver and perhaps even how we structure clinical trials. And I think one of the revolutionary things with precision medicine is kind of moving away from tissue-based therapeutics to be more tissue agnostic, and focusing more on shared biomarkers or shared molecular pathways that may be perturbed independent of where the tumor may have anatomically originated. So I'm wondering if you might just talk a little bit about this paradigm shift and adopting more of a tissue agnostic cancer therapeutic approach, as it both comes to how we think about structuring clinical trials and then also how we think about it in the clinic when trying to identify therapies for patients with cancer.
It's a great question, and this is a major paradigm shift, in the management of cancers and in FDA approval processes. As you said, I mean, we're classically, we've been all taught to think about, what diseases we can take care of. And I ask you what you do, and you're going to say liver, pancreas, and I'm going to say, sarcoma and liver and GIST, or, if you ask me what I do. But yet, when we start thinking about this and take a step back at the histology level, we can go deeper dive, and we start realizing there are mutations in genes that cross disease types. And so what the sort of evolution has become is that things like the tumor mutation burden or the microsatellite instability, or often examples being gene fusions, such as the NTRK gene fusion or the RET gene fusions. Those patients with tumors bearing those alterations, what the data would show is that those actually respond in a fashion indifferent to whatever the histology is. Why this becomes important is because as we start thinking about designing trials, just as an example, roughly about 0.5% of tumors across the board have fusions in the NTRK genes. So if you took, 100 patients, you'd maybe get one responder, if you did, the math. But if you enrich for patients with NTRK fusions and said, okay, we're going to take only patients with NTRK fusions and give them an NTRK inhibitor, now you start getting into response rates in the 80s, +% range, depending upon the drug and which study you look at. And so you can get a tremendous enrichment of the right patient, the right drug. But, it's important to understand that this isn't just simplistic as, the patient has, the report says there's something going on in NTRK, give them an NTRK inhibitor. You still have to understand it at a deeper level is, for instance, with the NTRK inhibitors, the mutations in the gene don't lend themselves to responding to therapy. It's only the fusions between two different genes that leads to activation and response to this therapy. So, we need to be careful in terms of just as, we're learning about this, of trying to identify what's the right drug and the right target. And that's where, like in the articles, it really breaks down for across the disease spectrum of diseases, what are our targets for different histologies, but also what are the targets that can be histology independent. And, these articles really lend themselves to being a great resource, even for very experienced people in the field, can still, I think, learn, a lot from these articles.
You've kind of, touched on this, but maybe just for our audience to kind of sum it up. But I'm wondering if you just, touch a little bit on the difference between maybe like an umbrella trial versus a basket trial, and how that relates to like precision medicine, how we think about accruing patients to different types of trials.
So the concepts of umbrella trials and basket trials are really really focused on the way the trial is designed. So, we're classically thought to think about a trial whereby, we have histology X, and, we're going to randomize the patients to placebo versus, some single or, multiple chemotherapy agents. And, that's been our classic, randomized clinical trial design that we've had for many, many years. The way that a basket trial works is it's an approach whereby we think about one gene, across different histologies. So, you have patients with breast cancer, stomach cancer, gallbladder, and if they have biomarker, X, such as an NTRK fusion, you would give those patients an NTRK inhibitor. And so, like, the NTRK story is really a good example of the basket trial concept. The umbrella trial concept is really taking one histology and then breaking it down into the different genetic alterations that are identified in that histology. So, good examples being lung cancer, taking and identifying EGFR mutations versus patients with ALK fusions, and identifying what drug would be targeting the EGFR versus the ALK in those situations. And so, these are all trials based upon the fact that you have sort of a small compendium of either genes and or drugs that you're trying to match together.
Yeah, that's really helpful. Thank you. So I wanted to now move on to, the last article that we're going to discuss today, and that's the article by Dr. Kurzrock and colleagues around kind of the evolution of precision oncology and personalized medicine and kind of moving into the future. So, we spent, some time, chatting about, molecular testing, identifying a specific gene that may be mutated or a specific fusion protein, and then targeting that one thing. And I was wondering if you could comment, I know there's a lot of work you've personally done in this area about the next iteration of like this whole concept of, an N of one trial, where, we basically identify perhaps multiple different pathways or multiple different genes, and then target them at the same time.
It's a great question, and it's really something that, as you mentioned, is clearly evolving over time. I think taking a step back is, as we're learning about these tumors, pan histology, number one is, while we have these basket trials or the umbrella trials where we're saying, okay, there's one mutation or there's one driver, we're going to target that. What we're realizing is a lot of these tumors don't just have one mutation. They've got multiple mutations. And, where historically the field has been is that the early days of precision medicine were sort of predicated on using either immunohistochemistry to then identify a target and giving a single drug, or then subsequently in the early sort of 2000s teens of doing single gene testing of, one gene, that gene's not there, finding the next gene, oh, they've got a mutation in that, we'll track them to a clinical trial where they might get a drug to target that. What we saw is, if sort of in terms of like sort of maxing out, if you will, if we look at patients that get non-precision targeted therapies, meaning most of the time this is often like on a phase 1 clinical trial, response rates are roughly about 5%. If you start taking patients and dispelling them down to identifying the right molecular target with the right drug, we start seeing response rates upwards of like 30%. But if you're sort of, a glass half empty person, you might say, well, what about the other 70%? We're clearly not there yet. And so, that's where you need to start taking another step back and thinking, well, there's not just one target, there's multiple targets. And this is where, we're still in earlier days of this approach of thinking about targeting more than one alteration. And, can we start thinking about giving really not just precision, meaning targeting a drug to a therapy or to a target, excuse me, but thinking about personalized therapy where we can start thinking about the individual patient and what, multiple alterations they might have in order to target them. That's sort of the next step of the N of one. And, where also, sort of is evolving is our understanding of how to put this all together. And this is where really the concept of the molecular tumor board comes in.
Yeah, that was going to be my next question, is to kind of wrap this up and put a bow on it, is, for kind of like practicing surgeons, right? That traditionally, we bring all our cases, many of our cases, to a multidisciplinary tumor board. So in the evolution of this, we have a surgeon, a medical oncologist, usually a pathologist, a radiologist, et cetera. But how do we broaden this concept? And you started to touch on molecular tumor board when we bring to the table, even AI, big data, the molecular information, because this can be a daunting task, right? Trying to identify multiple different, mutations or fusions, et cetera. And then also trying to identify which agents could potentially target all those different mutations. And, I think most of us, including myself, would find it, near impossible to do that in the currently construed multidisciplinary setting. So how do we move to a more sophisticated, molecular tumor board where those people are at the table? So we are not only thinking about, cutting it out and giving traditional chemotherapy, but we're more also thinking about really delivering state-of-the-art molecular care.
You're absolutely right. I mean, the molecular tumor board, the beauty of it is, it's not like a single person. There's no way for all of us to keep track of the evolution of how much data is coming out, literally every day, or keeping track of all the new FDA approvals of new drugs that are becoming available. Understanding what every, genetic report or genomics report even means, and that's where having a molecular tumor board, we're really putting multiple people's heads together is important. We did a study here at UC San Diego several years ago where we looked back retrospectively at data from our molecular tumor board, which really includes the traditional things you mentioned: medical oncology, surgical oncology, radiation oncology, pathology, radiology, but it also includes some basic scientists. It includes medical geneticists. It includes computational biology experts, all sitting around the table together discussing, the patients and their alterations. And what we found actually was that patients who were discussed in molecular tumor board, and if the treating physician decided to just completely ignore all the recommendations, the patients did worse than if the treating physician followed a portion of the recommendations. And then, the best results were those patients that followed all the recommendations. And so it really speaks to the concept of team and bringing people together with different specialties, different knowledge bases, different experience, to be able to provide the best care for our patients. And so, it's a challenge. It's a challenge for these to be done at every institution. There are a lot of molecular tumor boards that are available online or more, nationally or globally even. And so for those folks practicing in institutions where they either don't have it or in smaller community-based settings, there are opportunities and there are ways to engage into this, approach with, with this new technology and this new knowledge. And, speaking to the AI, we're still early days on that. Certainly, as we're realizing, there's tremendous power to artificial intelligence. And I think, we're going to obviously have to be careful as we move forward with that data and that knowledge, but it's certainly going to be something that will get rolled into what we're all doing because, again, it is impossible. It's just impossible to keep track of all the data published every day, and be facile in all of it.
Well, this has been a great chat with you, Dr. Siklik, about this important topic. I really want to thank you for your time today. And perhaps even more importantly, thank you for your leadership of this important volume of surgical oncology clinics in North America. You did an outstanding job putting together a really a tremendous group of authors. And, I do encourage all of our listeners to check out the articles in this volume. I think you'll find this topic to be very germane, very timely, and very well explicated across the pages of this volume. So thanks again, Jason. Really appreciate it.
Thank you very much for the opportunity to do this. It was an absolute pleasure, and I hope that the readers learn a lot. I actually learned a tremendous amount as I was reading through and the chapters, and I think others will as well.
Great. Thanks again, Jason.
Thank you for joining us for this Surgical Oncology Clinics podcast devoted to precision oncology and cancer surgery. The 4 articles discussed, as well as 10 others, are in the April 2024 issue, Volume 33, Number 2. This series is available for individual print or online subscriptions. Visit www.surgonc.theclinics.com to subscribe. This series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on X/Twitter @Surgical Clinics, and you can find our podcast on YouTube, Apple Podcasts, and your favorite audio streaming platforms. Thanks for listening.